We're going to go through this quickly. We just have some case studies. And am I supposed to sign my own name?
Okay.
Okay.
I got you.
Appreciate you.
That's good.
Okay, acute coronary syndrome. We have worked a lot of cardiac patients in our careers, be it 40 years, be it 2 years as a medic. So a lot of our calls that are truly life threats. And you can see here, and I'm going to read all this, but stable angina, unstable, non-STEMI, and STEMI. And there are ways to tell which is which. A STEMI, to me, is pretty easy to determine that, hey, this patient is probably having a STEMI. We'll just go over some of the differences, obviously, between them. I'm not going to go through this coronary artery with it. Well, one thing I do want to go over just very quickly. Okay, you have two main coronary arteries. You have more than two. You have more coronary arteries than two, but your main, you have the right and the left, and then it branches into. And you can read as well as I. And obviously, the right coronary artery and its branches feed the right side of the heart. The left coronary artery and its branches feed the left. And there's one up here that if your patient has an occlusion in the LAD, LAD is the largest coronary artery, by the way. What happens to those patients that are 100% occluded? What happens? They die.
So
Yeah,
say,
Unless you can get them to a PCI capable hospital ASAP, so that they can do what? Stented. Or if they had to bypass. That one's called the widowmaker. If it's blocked, you're dead. There's people out there that appear to be healthy, walking around, boom, 40 years old, fall over dead.
How many did Gary
And
know
LAD.
about?
Stents,
Yeah.
Gee.
12.
Yeah, he had a family history, very significant for coronary artery
Yeah.
disease. His brother died of it. I think his dad did also.
Chris Furlong, be nurse, ground, and police officer. He's got 13 right now.
that's really good.
Chris
Lord.
Furlong
That, to me, would be about a record.
was married to Mecca, or is married to
Is
Mecca.
married.
Yeah. Yeah, his last one, he got 3 stents. They left White River. He made her stop at Freddy's and get him a cheeseburger before he got from Freddy's to Cherokee Village. She had to pull in there because he was having another damn heart attack.
That's, wow. He used to work here.
Yeah.
I worked with him up in prison.
Really? I hadn't seen him in
He
years.
used to own the restaurant, or, yeah, he managed the restaurant on the corner of 223 and 62.
Oh, okay.
And he was my boss. So.
Okay.
Yeah. He used to make strong coffee.
Anyway, you've seen this picture before in your textbook,
That's what she remembered.
I never remember.
but there you can see the LAD is the largest. There's your right coronary artery, circumflex, right marginal, etc. Okay. We actually have some case studies, and we'll go over them pretty quickly. But stable angina means this, that the patient generally is stable. What happens with this patient generally is they're going to be doing some kind of activity, okay, whatever it is. They start having chest pain. They go to the house, sit down, relax, chest pain goes away. Doesn't mean that they're fine, because it's a problem. If you start having chest pain and think it's cardiac in nature, obviously you need to be getting some treatment. So what are the signs and symptoms? There again, they had chest pain upon exertion. When they came into the house, sat down, rested, it went away. How would you treat this patient? I'm not giving you any more information. What would your treatment be?
O2, cardiac 4 weeks.
Okay.
Blood sugar IV.
Excellent. Good blood glucose, obviously.
Glucose.
And would you give me meds for? So we're assuming that the blood pressure,
Depending
heart
on
rate's
what my
fine.
12 lead says, aspirin.
Okay, your 12 lead is not going to show any depression or ST elevation and stable angina.
Well, your symptoms have resolved.
And they may AMA. But here's the thing, that we're patient advocates. We need to inform them that, okay, I understand. You had chest pain, you sat down and went away. That's a warning sign. that you need to see your PCP at a minimum.
What I can do out here is not gonna tell us everything you need to go get.
So
blood.
are
Your
you-
12 lead is not gonna tell you jack.
You got, is there gonna be differences between stable angina and pleurisy?
One way you can tell pleurisy, because I've had it, this is from experience. When you breathe, it feels like a ripping. Because your pleural wall, the cavity, I can't even think anymore, that it basically sticks together. Because you have an inflammation. And it pulls, it hurts. But if you stop breathing, it's not a good thing for a long period of time. You're not gonna have that type of pain. The chest pain, we know it can be dull, it can be sharp, it can radiate, it doesn't have to radiate. That's only, and that's just from experience. I've never had a heart attack, no, never want one. So I'm just saying that's how I would be able to probably tell it with pleurisy versus cardiac versus stable angina. But here's the thing, Tasia, we don't know for a fact, do we?
No.
We don't know. That's why we're taking that place called a hospital at emergency. Okay. Unstable
If-
angina.
On your cardiac, if you have a patient that complains of indigestion, they describe it as comes and goes. These are those where they haven't been sleeping on and off. Those always should marry a 12 week, because even if they tell you they think they have stomach bug, if they can't, if they're restless, if they don't wanna sit down, same thing.
Yeah.
And they're describing it as comes and goes, in all probability, they may have an atypical presentation for MRI.
They can. And here's the thing, just because there's a lot of patients, people out there that says, it's just indigestion, I've eaten a roll of Tums, still got it. Well, to me, I would say it's probably not indigestion at this point.
Well, the criteria for that one seems to be when it's atypical presentation is when they're around 70 or a little older, when they get right up there close to 70, and poorly controlled diabetes seems to be the other one that goes with it.
Well, one thing about your diabetic patients too, especially your elderly female diabetic patients, they do not have typical, not all, generally, they don't have a typical pain that you'd associate with an MI. Okay?
Right.
So one thing that leads me to believe that these elderly female patients, it's a cardiac event, if they're dizzy or if they had a syncopal episode, it's either a blood glucose problem, it's bottomed out, it's a cardiac problem. So just because they do not have a typical presentation, you still need to do that 12 lead. If someone tells me I had indigestion for 2 days,
That's
well, are you
what
on medicine? Well, yeah, I take pills, blah, blah, blah. Well, this may not be indigestion, and that's when you obviously would do a 12 lead. They may say, I don't need a 12 lead. Explain, though, I think you do, because when you're doing this job, let's make sure you don't have, a STEMI or non-STEMI exception. So what kind of presentation with this patient that has unstable angina? What is
Chest
unstable
pain.
angina? We have chest pain. And generally, when does it occur? At rest. At rest.
At rest.
Not always. They can be out walking around, have chest pain, come sit down, and doesn't subside. Doesn't go away. So is this a problem? Yes. Because at some point, it can progress on and it won't be an unstable angina, non-STEMI. And it's a little bit difficult sometimes to determine what is unstable angina and what is a non-STEMI on the 12 lead EKG. Because they'll both have, a lot of times, VST depression. Usually will in a non-STEMI or a bundle branch or something. Well, bundle branch not indicates STEMI. But they also, in the patients with unstable angina, because there is some blockage there, that they may have some, it hasn't infarcted yet, but it's getting ischemic because of the block. And you'll see ST depression in consecutive leads. Treatment on that patient, basically the same, look at IV cardiac monitor. If it's indicated, it's not contraindicated, excuse me, they may take nitro. Ask them, have you had nitro? Don't take nitro. Well, blood pressure's fine. I think we need to give you this and explain what's going to happen.
Yeah.
They may need aspirin, because we do not know, although the signs may be there that says it's unstable angina, we don't know if they've infarcted or not. So what's the best case scenario? Treat them as if they have. So they would want your Mo2 IV, cardiac monitoring, aspirin, nitro. You may even consider a little bit more things. Now, which is a better drug for cardiac? Fentanyl or morphine? Morphine. I don't know that. Because I called a buddy of mine that's a doctor, and we had a long discussion about it. And he explained why. And I'm not going to go into it because a lot of it's over my head. He said morphine is the best cardiac drug there is, as far as for the pain, because it has properties that affect the cardiac system that fentanyl doesn't have.
What about a first responder, here locally, he's 31. He's going through a lot of what you're going through. He's supposed to have an ablation the third. He's supposed to be being set up for a pacemaker. And the last time I picked him up, he was running a call with us, and it was me and Chris, gray, ashy, cyanotic, had chest pain all day, had ignored it, and I'm afraid to death that we're gonna code this kid before he gets in.
When's he having his ablation?
They keep putting him on.
Well, it obviously has AFib or flutter.
Well, he
One or
ran
two.
into, he had AFib, and then he went into SVT, he cardioverted while he was with me. And he said that Mountain Home, we took him to Mountain Home, because that's where his cardiologist was at. They gave him I think a Prevacid or a Prilosec or something, and told him to go home, so that it was gastric.
There's nothing to say he didn't have two things going on at the same time.
Yeah,
Yeah,
well,
So, but still,
he was in Carson's office the next week,
they're saying
same
if
thing,
you have everything showing cardiac,
yeah.
I would think that they would, I don't know
I
what all they
mean,
did, obviously, but they would have worked it up. you would think.
Classic signs, dyspneic, chest pain, and as soon as you gave him nitro, he felt better, he just,
Yeah. I mean, I don't know.
Did you
like
transfer
this,
him
but-
to ambulance?
oh, yeah. Yeah, after I flew my guy out.
I don't really know what to say about that because it's being recorded.
Yeah.
Did you take him?
Yeah, no.
Did,
No, you know,
did they, do you know what all workup they did on them? Okay, you don't, so that's it.
No, I know they've had him on a monitor for a while, because he was sending me the rhythms
Okay,
and I mean,
Well,
there's periods,
You know,
and I'm not an
the thing about a monitor, and I don't know what they do there, most times when they're on a Holter monitor, on a monitor in a ED, they're monitoring in lead two. The only reason they monitor in lead two generally is because it gives you the best of the leeway.
I don't see a blast on there, but.
I mean, surely the God did it 12 weeks. I would have done multiple.
I know when I walked out, the doctor was talking about, I guess one of the internalists had said that it was more gastric than what it was cardiac, and so,
Well,
I mean, they were already getting ready to do the paperwork on discharge before I even walked out the
Okay.
door, so. Chris walked back in, when he did, they were drawing blood then, but, I mean, we just got back, and they said, oh, he said, they said,
well, you could have waited to give him a ride home, I guess. Sorry. I'm not really, I wasn't there first of all.
yeah,
Okay, let's get through this. Okay, 55-year-old, lawn yard, blah, 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 50% humidity. That's not very high in Arkansas in the summer, but anyway, 85 degrees, develops chest pain, goes in the house, sat down in his recliner, pain subsides after 5 minutes. What do you think's going on? Just, I mean, you know nothing else other than this. Huh? What time? Stable. You don't have all the information you need, but just because we know this, we're talking about unstable, stable,
The fact that he went in the house and it subsided after 5 minutes.
right?
It was brought on by the fact that he was.
He's not working, he's exerting himself. Now, what's happening here? Why do you suspect that they're having chest pain when they're out working? Okay, but what happens when you exert yourself? Your heart starts beating faster. It requires what? More oxygen. Okay. So he may be getting a little, I don't want to diagnose them, I'm capable of doing that. But that's one thing that's happened, and then when he or she goes, sits down and subsides. His heart rate drops, start breathing normally, everything's fine at this point. Okay, this next patient looks like me, we've had him before. And that just shows the placement of the EKG path. We're not gonna go over 12 lead, say, hey, you put the bad here or there. If we don't know at this point as medics, we probably need to get out of the career. But we do a 12 lead, and here's what we see. This is patient number 1. Can you see it well enough?
It did.
If you just look at this, if I just glance at that, I don't see a thing wrong with it. Even if I get up and get my glasses on, I think, maybe a little rapid.
I see a lot of it.
But there's, do you see anything that looks like
I just see the
ST depression or ST elevation?
No.
You trust me, it is not on this one. I did put this on here, obviously. So you did this 12 lead on patient number 1. Is out mowing. He, like me, needs to lose about 80 pounds, but his EKG is okay. Okay. Does that mean that he may or may not have a cardiac issue incident 20 minutes from now? No, it doesn't mean that. But when we see this 12 leads, we're pretty happy with it. Okay, assuming that the vital signs are within normal parameters. Okay, now going over this, most likely unstable stable angina. You'd want to get a history on this patient, any meds, if you're having cardiac history, etc. Treatment, well, if he wants to be transported to IV cardiac monitor, 12 lead taken to the hospital, should they be transferred? Probably so, but they may choose not to. Okay, would you need to take this patient to a PCI capable hospital? No. Why?
Somewhere just up to check troponin.
They can come up here and do that.
Yeah.
He's not having a STEMI, he's not having a non-STEMI. He's not having a bundle branch, left bundle branch block. Okay. Now he or she may request to go to OHC or BHC, that's fine. But they're not having a STEMI. This one, quickly, watching television, has chest pain, hasn't subsided after 20 minutes, as is your hypertension. Takes Benacar, HTC, that's a blood pressure medicine, also makes you pee. And,
How would you know that?
because I'm a smart man. I used to take it, I don't anymore.
There it is.
But, yeah, there's that. You want me to lie? I'm gonna stand up here at almost 66 and lie. You know? Yeah, almost.
Why not?
And nitro PRN, what's this patient's most likely problem with? This is all we know at this point. We're going to suspect what? Initially. Well, it's angina, obviously. It's unstable, but we don't know. It could be a non-STEMI, it could be a STEMI, couldn't it? We don't know that. But we got this little tool out there that we use. It's called a 12 lead EKG monitor. And we slap this bad boy on, and we get to looking. Hey, I'm seeing some ST depression. Can you see that? So, but you don't see any ST elevation. That's the only place you see it, okay? So this patient is probably 99%, they're not having a non-STEMI, okay? This patient has unstable angina. They have some ischemia going on. So are we going to treat them? What do we want to do to this patient? What would your treatment be for this patient? We know O2 IV cardiac monitor. Would you want to give them any medicine? We're assuming the vital signs are within normal parameters. Hey, I might throw a little nitro, aspirin, give them one more thing.
Mona.
Give them some Mona. I'm gonna tell you, can I tell you a story back in the day? This is how long, there's been people in a lot longer than me. A live Pac 5 was a state of the art.
Oh, good Lord.
If you had a live Pac 5 36 years ago,
We've got one back there.
I don't even want to see it. But let me tell you about live Pac 5. Back in those days, almost no ambulance service did 12 leads.
Right.
Baxter may have, I don't recall. We did 12 leads. But we went through, I was an ACS instructor, was obviously a medic. And what we learned in medic class and ACLS, if they had chest pain, moan to that person, morphine, oxygen, nitro, and aspirin. So we'd throw it down, and you throw it. And guess what would happen? Bam! They went into cardiac arrest. But you know what? Thank God I was there to save them. Defibrillate them, got them in. My partner, I high five. You know what they had? An inferior infarct. I damn near killed them. It was almost a pad. You know what a pad is? A paramedic assisted death. So I'm telling you, that happened a lot. I'm not making this up. This is true. You can ask Stacy Wright. He was with me when we did it. And we were just so proud. Yes, we high-fived after that call. We thought we done great. And then a few years later, you're going, oh, wait a minute. We got to do 12 EKGs. We started doing 12 EKGs. Like, don't ever give nitro to somebody that's having an inferior infarct because it decreases the preload. Your patient's pressure drops. Then infarction increases. What happens to them? They die.
Faster.
So anyway,
Did they ever show you, or did they ever advocate for you guys to reposition the pad so you get a different look? Basically,
okay, let me tell you something. A guy named Frank Bain,
Yeah, right.
probably the smartest, one of the smartest. He's, and I'm not bragging on myself. I used to be a pretty good medic back in the day. You ask some people, I'm not lying. But he's the only medic I've ever deferred to in my almost 40-year career. Frank Bain, with a 3-lead monitor, could do a 12-lead.
Yeah.
And he showed me how to do it. I think I don't particularly want to take the time to do that, but he would do it. And he would do those 12 leads with a Life Hack 5. This guy was the most incredible, smart. He could make anything. He went and got his aeronautical degree. He's a pilot for Delta. He's a flight instructor. He got his GED, guys. First day, can I tell just a little story? Come to EMT class. And this is why I hate people that make fun of folks. He's living at the boys' ranch, if you know what that is.
That's where I work.
Okay. He had a pair of tennis shoes that was duct tape. People making fun of him. Tim never did care for that much. So I kind of took him under my wing, so to speak. I'm not bragging on him, I'm just telling you. And then after that, people, oh, Frank must be okay. And they figured out this man just got a GED. He's one of the smartest people I've ever met. And he was the best medic. And I met some damn good ones, excuse my language on you in La La Land, that I ever worked with. And I worked with some good ones at men, at Cersei, Batesville, one that did Fort Western stuff. And then at Baxter. I'm telling you, he was the best of it. He should have been a cardiologist or a cardiovascular surgeon.
There's a few of us up here years ago that did try to get out to the full 12 lead by the time we got there.
It can be done. It can be done.
It took a while.
Yes, it does, but it can be done. But anyway, that wasn't a war story. I was just talking about a guy that I respected a lot. So anyway, that patient we've already cured, hadn't we say we did. Okay, check this one. Don't even tell me what thing's going on at this point. We're gonna do a 12 lead, right? Let's look at this 12 lead. Hey, this don't look very good. Well, okay. Be regular. Well, no, flutter can be regular. But look at this. Do they have some SD depression?
Yes.
Yeah. Low. This person is having what? He's having an MI. What type do you think it is? It's a non-STEMI. Okay, now, here's why you always do a repeat. We're not getting into treatment on this one yet. Okay, here's why you do a repeat one. Stuff changes. Nothing stays the same. Well, that's not true. It's systole does. Person is systole in the ED. 4 days later, if you dig them up, they're still in that systole. So that don't change. But 15 minutes later, in your transport, you do this.
Oh, good.
Okay. It's changed here. You're not seeing this ST depression, are you? But what are you seeing? Well, you're also, you need to be looking.
V1 and V2. I can't see beyond that.
Okay, what are they having?
No, we're.
Now we're pretty sure that they're having a what? Can somebody tell me what time? Wait a minute, let's see this. L-I-S. Septal. You remember at least the L. Everybody remembers that, don't you? Yeah, I was taught. So with this patient, let's say the blood pressure, let's just say it's good. I'm gonna just throw a curveball at it. Let's just say the pressure is 140/90. Heart rate is as you see it, it's not that rapid, is it?
No.
Probably what in the 70s, 80s, whatever. Respiration rate is 20. But they're having a problem and they got chest pain. What would you do for this patient? Now this is not an inferior infarct. Septal. The pressure is good. O2, aspirin, IV. You never give nitro without an IV. Ever. Ever. Never, ever, ever. But that's what you're gonna give. Give them a little morphine if they're not allergic to it. Okay. I'm trying to speed up.
No, you're fine.
Okay. Would you take this patient to a PCI?
Yes.
Of course you would. They need to go to CAT lab, don't they?
What is a PCI?
Spontaneous, what, help me out here, interventionalist, I don't know, ask Tammy. It means a cardiac, it's a cardiac interventionalist, but I can't remember what the P stands for. Hang on,
So like Baxter?
I won't think it's percutaneous, but
I would
let's see how smart my wife
Did
is.
anybody else know what PCI meant?
Hang on just a minute. No, don't Google it.
People know.
Actually, so that was like that.
Yes.
They're not PCI anymore.
It's cardiac interventionalist, but I don't remember what the P stands.
So like cath lab, right?
Yeah, yeah.
Okay.
It has a, I don't
Now you-
what is it, Mike?
Percutaneous.
Okay.
coronary
That was close.
intervention.
Okay,
So
I
cath
said
lab.
cardiac, that's
Yeah,
pretty
cath
close.
lab.
Medical procedure used to treat narrow.
Why are you
and
using
blocked
all these big
coronary
fancy
arteries.
words?
Take them to the
If it
hospital.
says PCI,
The
it means take them
hospital, not
where
the
they can have
hospital,
heart
not the
surgery.
hospital.
Let me ask you a question quickly. You've got a long transport time to go on to Baxter.
Yeah.
You've done your initial EKG in the house. You did this one, what, 10 minutes later, whatever, it's like the lies made up. Would you do another 12 weeks?
Absolutely.
Absolutely.
Oh, yeah, 2 or 3 minutes.
Absolutely. And you're gonna do what? You're gonna, well, we can't send them through our 15s yet. We're gonna be able to eventually.
Well, your monitor should start spitting them out.
Yeah, they'll, yeah.
Fitting what out?
When there's a rhythm change, your
Oh,
monitor
okay.
automatically turns.
Okay, you have to understand I'm old school. I was thinking, okay, I'm gonna, if it doesn't spit one out quickly, I'm gonna go ahead and do another one.
No, I did left the other day. I'm like, why did you want?
But anyway,
There's changes.
Cause you went around a corner and it kind of jostled a little bit when I went around the corner.
oh, 4. I'm not gonna read it. You can read it.
72-year-old
Maybe.
male with chest pain radiating down left arm, shortness of breath, and diaphoresis. 12-lead EKG shows ST depression. And leads 2-3 and AVF.
Okay,
History of cardiac bypass, 3 vessels at age 61. What is your impression of the patient? Oh shit.
well, we got a problem.
Yeah.
Okay,
Do a
This
right
is- this
side.
is hard.
probably.
if you wanted to, you could do a right side one. How many of you's done a right side one? But
Never.
not hardly ever. Have you ever done a 15 or 18?
No.
In
Me either.
class.
Me either. So,
In class I did.
okay, you see if you could get up there close, you would see the expression. I'm gonna move right along, okay? Would you repeat a 12 on this person?
Yeah.
Is this patient suffering from the infarct? No, you don't know that from the first one, did you? That was depression. I mean, it could be a non-ischemic, okay, but at least they have ischemia. But here's why you do another EKG, same one, same patient.
Oh,
Oh, lovely.
Now, what is wrong with this particular patient? Classic inferior infarct.
he's about to be Jesus.
You know how to treat that, obviously, do you not?
Diesel.
Well, yeah.
Dear Lord,
and
it's
other
me
things.
again.
This is an actual patient that Fulton took to the hospital. I used to get feedback from OMC and Baxter.
Yeah.
When you take STEMIs or non-STEMIs.
I wish I'd printed them ones out the other day for you guys to look at.
Okay, we're not gonna look at that very long, but here's what they did. Is they're doing a cardiac catheterization. Now look at this here, look at this. Now here is after. It reperfuses patient. RCA, I'm pretty sure it's an RCA. And they used to get feedback. I don't get it anymore since Kim Foxworthy's not there. But what this allowed me to do,
When did you?
it's been about 4 years ago. And Tom Hawkins, I've met him once. He's never sent me anything. Probably too busy, I guess. But Kim would send this. The doctor would dictate this, and they'd say, "Okay, EMS did this, this, and this." Which you guys, whoever worked that, called it perfect. And then they capped them. They opened up that right RCA, and they give a prognosis. And this patient went home. You can't read it; it's too small. But the patient went home with her husband. Is doing fine. So this Kim would send this to me after you guys took the patient.
Do you want me to read it?
It just said you did a good job, whoever. But the only reason I show these are actual ones that we had here at Fulton.
Oh.
So that one right there, that just stands out. It says, "Damn, that's a lot." Okay, let's quickly move along. And this is what the medic. This is a medic's narrative. This is a good narrative. First of all, the narrative does not need to be a manifesto. You know what that means, a manifesto is? A narrative is just that. What is the pertinent information about this particular call and this particular patient? But they did a good job. Now, they did give morphine. Okay, and that was okay because the pressure was fine. It did drop some. How did I know that? Because I actually PI every run. So they did that.
After 2020.
Excuse me?
This was after 2020.
After?
Yeah, because it said all COVID screen.
Oh, okay. Okay. It's like I said, these have been a few years ago.
Yeah.
Not 10 years, just a few.
Yeah.
But then here's what they did. Actually, this is a transfer from Fulton. Ejection fraction. After they did RCA, they opened RCA up. It's 100% eclipse. That's a problem. But ejection fraction at 65, that's very good.
What's an exopan?
Where do you see that at?
Go
It's a
for
drug,
it.
but I don't know what it is. I don't know. I don't know what that is. I didn't do any research on that drug. The rest of them I can tell you what they are.
There's the Berlinta.
Anyway, it starts out. But here is it. But up here is a problem.
Oh, it's to prevent blood clots in the leg in
Now look.
patients who are on bed rest.
I used to work in the cath lab. After a while, it gets boring. But it was interesting. I do the hemodynamic monitoring, but I could also see the screen. This has been a long time ago, White River. And what they do is, the time they went in the groin, they'd cross the aortic arch and they'd go into the coronary arteries and they shoot dye. And when they shoot that dye, X-ray would start taking pictures, and you could see that it would light up the coronary arteries. And even as a medic, I can see, okay, that's blocked there. You know, it's easy to see, or most of it. But anyway, that went from that's a problem, to that. And then they gave this a different case study. It's a transfer from the ED, went to OMC. That's hard to see. That's EMS is sending the EKG. It's hard to see. I can't either. This is basically all I wanted to show you is crews do a good job. You can see where the blockage is here. After they did it here, and they did this. This is what they'd send me.
Mike's gonna interrupt you for just a
Can I
minute.
interrupt for just 1 second? Randy is currently transporting John Carter back to Baxter for rehab.
Good.
So,
Awesome. I
he said he's
texted him
only
on
had to
that.
threaten to put a pillow over his face twice.
Well, I can understand that. I've known Carter a long time.
Yeah.
But anyway, this patient, you guys did an awesome job. They got discharged. 638. This was a medic who went out, picked this patient up. This is the elevation in 2, V2, V3, V4. There's the EKG to Baxter. Here was the first EKG that you guys did. Honestly, you guys, I don't know who actually did the run. Even somebody's blind and say, hey, we got a problem here. Okay. Then they did another EKG at Baxter. Whoops. We're definitely having a stimming, aren't we? Let's look. For a central blockage. After they extended them, looks great.
You were sitting there, yeah.
And then they tell you that here's what happened. The prognosis is this person had other problems also for 56.
That looks more like mine.
And it may be, I don't know. No, this is what I got back from BHC.
Oh, okay. Yeah, that'll give you really kisses.
Or you probably didn't go ahead and,
Small aneurysm,
Yeah.
you see those too?
Yeah, I saw
well,
it.
here's the thing.
Well, it started,
Oh,
it
reason I
looked
had
like when it
this
started.
up here is because it shows you guys do good work. I don't get this any longer since Kim is not. And the guy that was at OMC is gone, so I don't get anything.
Do you wish you would?
I've actually reached out to ask, and it's gonna. Tammy said she'd take it. That's all I have. I went way too long on the first, and I think CHF is important.
You did.
I like
good.
this. I like this much more than CHF and LVAD as far as the actual 12 lead rhythms treatment.
Let me throw this question out. The only reason I'm asking this, because I think I know the answer, and I had another healthcare person at another facility acted as if they didn't give any, hold any weight. When Angie and I picked up a patient one night, I remember shortness of breath, maybe some chest pressure. We get there, she's had 2 stents in the last 4 to 6 weeks. Now, one was not cardiac, but it was still circulatory stent.
Okay.
Get her in a truck, left on the front, to be sure.
Was it
Started
new
talking
onset?
to her, and she had no clue. I said, she's never heard those words.
She'd had a 12 lead at some point.
Yeah.
Said it told her
And
she had it.
she has another cardiac appointment to do, right? I mean, she's still in the follow-up stage. On the way, 5, 6 times, she was having transient type 2 or 2nd degree type 2. Would laugh, come, would go away.
Mhm.
What do you think we were leading up to?
I think it's leading up to a shit show if you're over
But I
there.
mean, ultimately, what do you think?
Okay, first of all, she had a new onset of left
Yeah.
bundle branch block.
Yeah.
I'm treating that as a STEMI. Okay. But then you say they had transient second degree type 2
We coming?
AV block. This person's got a lot of problems.
Yeah.
Okay. As far as treatment, how slow was the heart rate?
It was pretty normal,
I would,
if I
I
remember
wouldn't be
correctly.
concerned with the second degree AV block type
That's
2.
all I
I mean, that's a
remember.
high degree heart block.
Yeah.
But that's not the primary problem. The
Yeah.
primary problem is this new onset of left bundle
Yeah.
branch block. I'm not that smart, but I do know that unless she never listened and the doctor said, hey, you got a left bundle branch
And that's
block.
it. I didn't
Who
know,
knows?
but I tried to explain what it was, and I said, because you may not know what it is, but have you ever heard this? If
Yeah.
they've just heard it, and a doctor's going to emphasize that, if nothing, or I mean, somebody will at least tell them what it
You
is.
saw a cardiologist, just my experience is they go very much in depth about
Yeah.
what your cardiac rhythm was. I mean, they did with me anyway.
So yeah, but when I got to the facility,
Mm-hmm.
they just were like, oh, okay. And I'm like, no, this is new, and we've got a lot going on.
Is this the patient you said to remind you?
Yeah.
Wow.
And it was like, and the doctor, now I will say this, the doc followed us into the room, and I gave a report to him and the nurse at the same time.
Yeah.
And the doctor turned to me, and he was walking out, he's like, now, I didn't get his opinion. I'm sitting there, and I repeated myself to the twice to the nurse, and it was like,
I don't, I don't like to critique unless if it's
I
my
know.
call or I was there, but that's just poor
Yeah, that nurse-
healthcare management.
I think the doctor
That's my opinion.
was like, she's sick. I mean, like, he knew this was not great.
All right, I'm sorry I to interrupt.
I'm good.
10-minute break, and we'll be back at 3, and finish up.
Okay.
Keep talking.
No, that's fine. I was
Okay,
just,
I have to go.
Okay.
Sorry.
You're fine.
I hope somebody got something out of that.
Yes, thank
I got a
you.
bunch of them. Thank you.
But anyway,
That was awesome.
thank you very much.
I always like to listen to him teach.